Yes, sir. Now start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a presentation on inflammatory and painful conditions of the genitourinary tract. This will be presented by our resident, Dr. Ashok, and would be moderated by our faculty, Dr. Manoj Bamaniya. So I would request Ashok to kindly share his presentation and go ahead.
Good morning, all.
Ashok, please.
Yes, sir. Good morning, all. My topic is pain and inflammation. Inflammatory and pain condition of genitourinary tract. Upper urinary tract kidney, pyelonephritis, acute or chronic infection of the kidney, glomerulonephritis, inflammation of the glomerular, nephrolithiasis, kidney stone, formation of stone in the kidney causing pain and possible infection, hydronephrosis of the kidney due to urine detention and secondary to urethritis, inflammation of the ureter, often secondary to stone or infection. In lower urinary tract, bladder, cystitis, inflammation of the bladder, often due to bacterial infection, interstitial cystitis, bladder pain syndrome, chronic inflammation without infection. In urethra, urethritis, inflammation of the urethra, often due to sexually transmitted infection, urethral stricture, narrowing of the urethra due to scarring. In male genital organ, on prostate, in prostatitis, inflammation of the prostate gland can be acute or chronic. Testis, orchitis, inflammation of the testis can be viral or bacterial. Testicular torsion, twisting of the spermatic cord leading to acute pain. Epididymis, epididymitis, inflammation of the epididymis, often due to infection. In female genital organs, ovary and fallopian tube. Salpingitis, inflammation of the fallopian tube. Oophoretis, inflammation of the ovary, pelvic cavity, pelvic inflammatory disease, infection of the female reproductive organ, open including the fallopian tube, ovarian and surrounding tissue. Classification by type of inflammation. In inflammation, bacterial, most common is E. coli, causing UTI and pyelonephritis, Neisseria gonorrhea, urethritis and PID, chlamydia, urethritis, epididymis and PID, mycoplasma causing urethritis in viral, mumps virus orchitis, herpes simple, in fungal, candida, parasite, schistosoma hematobium, causing urinary schistosomiasis. In non-infectious inflammation, autoimmune or immune-mediated lupus arthritis, autoimmune glomerulonephritis, interstitial cystitis, non-infectious likely immune-mediated. In chemical or toxic, chemotherapy-induced cystitis, example cyclophosphamide. Physical trauma, post-catheterization urethritis, post-traumatic testicular torsion. Classification by etiology, primary condition originating in the genitourinary tract, idiopathic interstitial cystitis and idiopathic chronic prostatitis. In congenital hydronephrosis, we are leading to recurrent pyelonephritis. Secondary condition, secondary to systemic disease or condition. In systemic disease, diabetic nephropathy and hypertension induced nephrosclerosis, metabolic sclerosis, metabolic disorder, gout leading to uric acid kidney stones, autoimmune disorder, SLE causing lupus nephritis, in malignancy, bladder cancer causing cystitis-like symptom, prostate cancer leading to chronic pelvic pain. Classification by clinical course, acute condition, acute pyelonephritis, sudden onset of kidney infection, often with fever and flank pain, acute bacterial prostatitis, sudden inflammation of the prostate with fever, pain, and urinary symptoms, acute epididymitis, rapid onset of scrotal pain and swelling, acute cystitis, sudden onset of bladder infection with dysuria and frequency, chronic conditions or chronic prostatitis, chronic pelvic pain syndrome, persistent pelvic pain and urinary symptom without clear infection, chronic pyelonephritis, recurrent kidney infection leading to scarring and chronic kidney disease, chronic glomerulonephritis, progressive inflammation of the glomeruli leading to chronic kidney disease, chronic interstitial cystitis, persistent bladder pain and urinary frequency without infection. Classification by diagnostic characteristic, symptomatic diagnosis based on clinical presentation, dysuria frequency and urgency, suggestive of cystitis or urethritis, flank pain and fever, indicative of pyelonephritis, pelvic pain or perineal pain, suggestive of prostatitis or chronic pelvic pain syndrome, laboratory and imaging diagnosis, urinalysis, hematuria, pyuria and bacteriuria, urine culture, identification of positive bacteria and antibiotic sensitivity, imaging, ultrasound to evaluate for stone, hydronephrosis or anatomical abnormalities, CT scan for detailed imaging of kidney stone, abscess or tumors, cystoscopy, direct visualization of the bladder and urethra for structure abnormality or interstitial cystitis. Classification by treatment approach, medical management, antibiotic for bacterial infection, example UTI and prostatitis, anti-inflammatory drugs for pain management in condition like interstitial cystitis and chronic prostatitis, immunosuppressant for autoimmune condition like lupus nephritis, surgical management, lithotripsy or ureteroscopy for kidney stones, prostatic surgery for severe cases of chronic prostatitis or benign prostatic hyperplasia causing obstructive symptoms, laparoscopy for diagnosis and treatment of PID, severe endometriosis or ectopic pregnancy, urethroplasty for urethral stricture, urinary tract infection, bacteriemia, which is the presence of bacteria in the urine, WBC in urine, bacteria without and pyuria without bacteria. Definition of urinary tract infection. UTI is an inflammatory response of the urothelium to bacterial invasion that is usually associated with bacteria and pyuria. UTI terminology, first or isolated, never had a UTI, unresolved, not responded to antimicrobials, some bacteria, some resistance, or third recurrent. Pathophysiology, UTI occur without when bacteria enter the urinary tract through the urethra and begin to multiply in the bladder. Although the urinary system is designed to keep such microscopic inverters, these depends something what are called. When that happens, bacteria may take hold and grow into a full-blown infection in the urinary tract. Risk factor: women are at higher risk due to shorter urethra. Which shorten the distance bacteria must travel to reach the bladder. Sexual activity, use of certain type of birth control, example diaphragms, menopause, and urinary catheter also increase the risk. Diagnosis by urinalysis, detect the presence of WBC, RBC, and bacteria. Urine culture, identify the specific bacteria causing the infection and determine the appropriate antibiotic treatment. Antibiotic are the primary treatment with the choice depending on the bacteria, identify and the severity of the infection. Increased fluid intake is recommended to flush out the bacteria. Complication: if untreated, UTI may lead to more serious condition like pyelonephritis, sepsis, and in rare case permanent kidney damage. Asymptomatic bacteremia should not be treated in premenopausal non-pregnant women, women with diabetes, older community dwellers, elderly industrialized patients, patient with SCI, patient with indwelling catheters, renal transplant patient before orthopedic surgery. Asymptomatic bacteremia should always be treated in pregnant women who are undergoing procedure in which transmucosal bleeding is anticipated. Complicated versus uncomplicated UTI. In complicated male gender, pregnancy, elderly patient, diabetic, immunosuppressant, childhood UTI, recurrent antimicrobial agent use, indwelling urinary catheter, instrumentation, hospital acquired infection symptom for more than 7 days, and obstruction. Interstitial cystitis. Pathophysiology, the cause is not well understood, but may involve a defect in the bladder lining leading to irritation and chronic inflammation. Other theories include a autoimmune response, nerve dysfunction, or a muscle abnormality. This factor more common in women than men, particularly those in their 30s and 40s, associated with other chronic conditions like fibromyalgia and irritable bowel syndrome. Diagnosis by cystoscopy may show small hemorrhage or ulcer on the bladder wall. And potassium sensitivity test to check for increased sensitivity of bladder lining. Symptom-based diagnosis. Open diagnosis based on symptom after ruling out other condition. Treatment lifestyle modifications, including dietary change to avoid bladder irritants like caffeine, alcohol, chocolates, oral medication like pentosan, polysulfate sodium, antihistaminic, and tricycle antidepressants, bladder installations, directly placing medication into the bladder, and physical therapy. Complication, persistent pain and urinary frequency can significantly impact the quality of life, leading to depression and anxiety. Prostatitis. Pathophysiology, acute bacterial prostatitis is caused by bacteria that ascend the urethra and infect the prostate. Chronic prostatitis may involve persistent bacterial infection or non-bacterial factors such as pelvic vessel tension or nerve damage. Especially acute prostatitis is more common in young male, particularly those with the urinary tract abnormality or often certain medical procedure. Chronic prostatitis may be treated related to repeated UTI or stress. Diagnosis by digital rectal examination, the prostate may be tender or swelling. Urine and prostatic secretion test to identify bacteria. Imaging, ultrasound or MRI in complex or unclear cases. Treatment, antibiotic for bacterial prostatitis with prolonged course for chronic cases. Alpha blocker to relax muscle fiber in the prostate and bladder neck. Anti-inflammatory drug and physical therapy for chronic prostatitis. Complication, abscess formation in the prostate, chronic pain and potential complication in sexual function, pelvic inflammatory disease. Pathophysiology, PID is typically caused by the spread of bacteria from the vagina and cervix to upper reproductive organs. The inflammation lead to scarring of the fallopian tube and other reproductive organ. Risk factors, sexually active women, particularly those with multiple sexual partner or who do not use barrier contraception. Previous history of STI or PID increase the risk of PID. Diagnosis, clinical diagnosis based on pelvic pain, fever, abnormal discharge, and the cervical muscle tenderness. Ultrasound may reveal abscess or a fruit collection. Laparoscopy is occasionally used for definitive diagnosis. Treatment, broad-based antibiotic to cover likely pathogens, Neisseria, chlamydia, Trachomoniasis. Hospitalization may be required for severe case or if patient is pregnant. Complication, chronic pelvic pain, infertility due to fallopian tube damage, and increased risk of ectopic pregnancy. Kidney stone, nephrolithiasis, pathophysiology. Kidney stone form when certain substance in the urine, such as calcium oxalate and uric acid, become concentrated and crystallized. These stone can lodge in the ureter and blocking urinary flow and causing pain. Respect dehydration, high protein, high sodium diet, obesity, and family history of kidney stone. Certain medical condition like hyperparathyroidism or inflammatory bowel disease. Diagnosis, imaging, CT scan without contrast are the most sensitive and specific for detecting stone. Blood and urine test for check for underlying metabolic disorder. Treatment, first is pain management with NSAIDs or opioid during acute attacks, medical expressive therapy with alpha blocker to help stones. Surgical intervention like lithotripsy or ureteroscopy for large stone. Complication, recurrent stones, urinary obstruction and potential kidney damage. Glomerulonephritis. Pathophysiology, immune complex or antibodies attack the glomeruli leading to inflammation and damage. And this can result in leakage of blood and protein into the urine and in severe case kidney failure. And respiratory including infection, post-streptococcal autoimmune disease, lupus, and the genetic predisposition. Diagnosis by blood test, a elevated creatinine, reduced GFR and specific antibody test. Urinalysis presence of red blood cast proteinuria. Kidney biopsy for definitive diagnosis into guide treatment. Treatment immunosuppressive therapy. Example, corticosteroid cyclophosphamide for autoimmune types. Control of blood pressure and proteinuria with ACE inhibitor or ARB. Dialysis in case of acute kidney injury. Complication, chronic kidney disease, nephrotic syndrome and progression to end-stage renal disease. Epididymitis, pathophysiology, the epididymis become inflamed, often due to bacterial infection in sexually active male. It is often caused by chlamydia trachomatis or Neisseria gonorrhoeae. In older male, it may be associated with UTI or prostatitis. This factor unprotected sex history of UTI and use of urethral catheter. Diagnosis by physical examination, swelling and tenderness of the epididymis, urine test and culture to identify causing positive organism, ultrasound to differentiate from testicular torsion, treatment antibiotic targeting the positive organism, pain relief with onset and rest, scrotal support, complication, abscess formation, chronic epididymitis and infertility, orchitis. Pathophysiology, orchitis is inflammation of one or more both the testes, often resulting in infection. The mumps virus is most common cause, particularly in post-pubertal males. Bacterial orchitis often cause alongside with epididymis respiratory. Unvaccinated against mumps, UTI, STI, or being sexually active with multiple partners. Diagnosis based on clinical presentation of swollen painful testicle, often accompanied by fever. Ultrasound to rule out origin and confirm diagnosis. Treatment, including systemic treatment with NSAIDs, pulse and test. Antibiotic is bacterial infection is suspected. Complication, including testicular atrophy, infertility, and chronic pain. Testicular torsion. Pathophysiology, torsion occur when the spermatic cord twist, cutting of the testicles, the blood supply. This is a medical emergency as prolonged torsion can lead to testicular necrosis. Risk factor including common in adolescent male, anatomical abnormality including bell cleft deformity. Diagnosis by physical examination reveal a high riding horizontally oriented testicle. Doppler ultrasound to assess blood flow. Treatment, immediate surgical intervention to untwist the spermatic cord and restore blood flow. In severe case, orchidectomy, removal of testicle may be necessary. Complication including infertility, testicular atrophy, and potential psychological effects. Urethral stricture, pathophysiology. A urethral stricture is narrowing of the urethra due to scarring, which can result from injury, infection, or iatrogenic causes, including example catheterization and surgeries. Risk factor history of urethral trauma, STI and previous surgery or procedure, including knowing the urethra. Diagnosis by uroflowmetry to assess urine flow rate. Retrograde ureterogram to visualize the stricture. Cystoscopy to directly observe the narrowing. Treatment including dilatation or ureterotomy for less severe case. Urethroplasty for long or recurrent stricture. Complication including recurrent stricture, chronic UTI, and potential kidney damage due to blood pressure. Thank you.
Ashok, so you can continue with the MCQs, then we will just briefly summarize the whole thing. Continue with the MCQs, yes.
Yes, sir. First is acute pyelonephritis is the most likely diagnosis in a patient with A. Fever, chills, and plague pain. B. Bacteria and pyuria. C. Focal scar in anal cortex. D. Delayed renal function. And E. VUR.
So yeah, so it's the diagnosis is very, very clear. Acute pyelonephritis will produce fever, flank pain, and on examination you can find tenderness over the flank region. Right. So I think next.
Bacterium without pyuria is indicative of A. Infection. B. Colonization. C. Tuberculosis. D. Contamination. E. Stone.
Colonization. Okay. All right. So
And
we all know that if there are pyuria is there, but if there is no bacteria, so it is called a sterile pyuria, where the diagnosis could be genitourinary tuberculosis, right? So bacteria without pyuria, maybe due to the colonization of bacteria, and there are no pus cells. Go ahead, please. Next question.
what is the most common causative organism in patients with acute bacterial prostatitis that develop after low urinary tract manipulation? A. E. coli. B. Pseudomonas. C. Proteus. D. Klebsiella. E. Enterococcus.
Yes,
E. coli.
E. coli. So, right. So E. coli is still the commonest organism in acute bacterial prostatitis after lower urinary tract manipulation. Pseudomonas is far more common in cases from manipulation compared with spontaneous or after transcatheter resection biopsy. Okay. Yeah.
The most common bacterial cause of genitourinary pyelonephritis is A. E. coli, B. Pseudomonas, C. Klebsiella, D. Proteus, E. Staphylococcus.
I think this is also very common. Proteus is the commonest organism. Yes, go ahead. Proteus, yes.
Mycosis contaminant bodies are associated with the following disease process: A. Genitourinary pyelonephritis, B. Malakoplakia, C. Renal echinococcus, D. Chronic pyelonephritis, E. Acute focal bacterial nephritis.
So anybody knows the answer in the class? So this is malakoplakia. Malakoplakia, they have Dr. Ashok has missed it. So malakoplakia is a chronic inflammatory condition which is caused due to chronic infection, and this may occur in any part of the urinary tract. And MG bodies, that is Michaelis and Gutman bodies, are typically found in malakoplakia, where they are found in the Hansmel cells. They are inclusion bodies which are found in the bladder wall in the cells. So this is very typical of malakoplakia, and usually caused by the chronic infection. And this was discovered in 1902 by Michaelis and Gutman. They were the two scientists who actually discovered malakoplakia. So again, malakoplakia is a very important condition which we should all know about whenever we are coming across this inflammatory and painful conditions of the urinary tract. Go ahead.
Treatment of renal echinococcus involve which of the following? Treatment with antibiotic and follow-up imaging to confirm regression of the hydrated cyst, observation, aspiration of cyst contents, surgical removal of the hydrated cyst, injection of the hydrated cyst with targeted antibiotics.
Yeah, surgical removal. I think these hydrated cysts need to be removed surgically. Yeah. So we have come across many cases, like we in last 2-3 months, we came across 2-3 cases of renal hydrated cyst. And this is important to know how to treat renal hydrated cyst. Yes, go ahead.
The most reliable early clinical indicator of septicemia is chills, B. fever, C. hyperventilation, D. lethargy, E. change in mental status.
So hyperventilation, okay, breathing, tachypnea, and that all probably is the commonest because of the metabolic changes as a result of respiratory alkalosis. Yes, go ahead.
Compared with non-pregnant women, pregnant women has higher prevalence of asymptomatic bacteria, B. acute cystitis, C. acute pyelonephritis, D. recurrent cystitis, E. bacterial persistence.
Yes, so some acute pyelonephritis definitely is more common in pregnant women. All right. And in 20 to 40% of pregnant women with the untreated bacteria. Okay, go ahead. So that was the last question. Right. So if the residents or faculty has any query, then we can solve that. Otherwise, we all know this acute and chronic inflammatory and painful condition of the genitourinary tract is an important topic where we routinely come across in our OPD many of these patients. It's not only just an acute bacterial cystitis or pyelonephritis. It could be non-bacterial also. We must also remember there are many conditions which is non-bacterial. There are many viral infection that can cause cystitis, fungal infections, then non-microbial kind of inflammatory conditions like interstitial cystitis or drug-induced. There are many various drugs which can cause cystitis, like cyclophosphamide, like ketamine, and there are various other drugs. So we should all remember these conditions of the urinary tract. Besides that, genital infection again is very important, like prostatitis, epididymitis, orchitis. And we must always remember the genitourinary tuberculosis, which is a common cause for chronic infection. Secondly, it could be the infections of the prepuce and the glands. Those are again very important. So balanoposthitis is a common infection that we come across, and it's very common in diabetic patients. So always do a proper physical examination in these patients, whoever comes with these symptoms. All right. So again, one of the most dreaded infection of the genitourinary tract is the Fournier's gangrene. Many of these patients may come with almost a kind of a gangrenous condition of the scrotum and the penis, and they have to be treated very aggressively. So you must remember all these conditions. So I would request Dr. Manoj to kindly wrap up the session. And if he has any remarks to make, please go ahead.
Thank you, sir. Good presentation and valuable information by you. And good session.
Thank you, everybody, and have a good day.